$479. And then on the credit card for December 15th, 2020, we also added $5,000 to our postage machine and $3,900. That's all I have. Anybody have any questions?
If no one has any questions for Janine, does anybody want to make a motion to accept the claims?
I will motion.
Second?
I'll second if you can hear me, Batman.
Can hear you.
Gotcha, Keith.
Gotcha.
Thank you.
Very good. Any opposed? Okay, we'll accept the claims. Thank you. Thanks, Janine. Is Lori on? Yes, she is. We're ready for you, Lori.
Hi, hello, everybody. I don't really have much to report. I'm trying to unmute myself, but that's fine. So, you know, we are still here, very busy here with early intervention and preschool special education. We continue to get referrals on a daily basis throughout this month and every month. I do still have one staff member that has been out on medical leave since June, and Bernita has decided to retire at the end of the month, so we're gonna miss her greatly. I was able to get a medical backfill for Bernita that started in October. She works part-time. It's Jessica Freeman, who actually was a service coordinator back in 2006 through 2011 with us. We were coworkers. So it was a win-win for both of us to have Jessica come on board and kind of fill Bernita's gap. But because Jessica is part-time, I do have to really requires a lot of oversight on my part for Jessica's role. And my staff here, the three that are here, plus Sarah and Nina, continue to are beyond busy doing their day-to-day activities in addition to daily COVID activities that we've been tasked with. So EI continues to go. We are doing a lot of therapies right now. I think we're getting back up to a combination of hybrid person services. It's still kind of scary with what's going on here in the county. I know the BEI would rather that services were done in a virtual model to the greatest possible, but therapy, as long as the therapist and the family are in agreement, the services being done in person. Caution from the health department, making sure that is still being done as we have a
is anybody having trouble with the video
And the audio.
feed? Right now.
I am done. Thank you.
All right, thank you, Lori. Does anybody have any questions for Lori? All right, thanks again, Lori. We'll move on to Eileen.
Hi, good morning or good afternoon. Okay, so you received the consent orders, so I'll just go through them quickly. The first one is with China Wok, that during the inspection there was a red letter violation, potentially hazardous food out of temperature. They are new operators of this China Wok, so this was their first violation, so we didn't charge them a penalty. The next one is with New China Royal, also a new operator for this facility. They had two violations, one potentially hazardous food out of temperature, and the other one is that they did not have face covering. So we did charge them a fine of $50, basically for the face covering issue. The next one is with Finger Lakes Variety and Sports. They were found with their employees not wearing face covering while within 6 feet of patrons. They signed a consent order and paid a $50 penalty. The next is with Leisure Acre Mobile Home Park. They did not take their nitrate sample that was required for the third quarter of 2020. That's their first monitoring violation in 3 years. They did take a makeup sample in October, and they signed the consent order that they will make public notice and collect their nitrate sample before the end of the year. The next is with Bass Pro. The employees were observed not wearing face coverings while within 6 feet of other employees and patrons. They signed the consent order and paid a $50 penalty. The next is with Arnold's Family Restaurant in Weedsport. Employees were observed not wearing face coverings, and they signed the consent order and paid a $50 penalty. The next is with Lakeview Mobile Manor, that they did not collect their required microbiological sample for October of 2020. This was their first monitoring violation in the past 3 years. And they did collect a makeup sample, and they need to take another one to catch up. So, and they will make public notice. And then the next is Walmart. They signed a consent order for employees and patrons not wearing face coverings while within less than 6 feet of each other, and they paid a $50 penalty. Then there was one that was sent later. I hope it was sent out on Monday, I believe, for Bayside Grocery up in Fairhaven, where they all their employees and patrons were not wearing face coverings while within less than 6 feet of each other, and they signed the consent order and paid $50. That's all I have on the consent orders. Anybody have any questions?
So this is a really stupid.
I don't have any questions. Does anybody else?
Can you hear me? Really stupid question is, it must be now a public health code that you have to wear a face mask, right?
Yeah. It's
Is there an expiration on this, or is this like something that's going to go on and on until somebody decides to revoke it?
Well, it's currently in the state sanitary code. They made it part of the state sanitary code sometime over the summer. So I would imagine at some point they're going to revoke it once this pandemic is over, but I don't know when. There's no expiration date listed in the regulation itself.
All right, because my concern that I've voiced privately, but I will do it publicly because we're live streamed, is that I don't like the thought that the health department is going to become an arm of law enforcement, more than it already is. I know we do the things with the restaurants and with the sewage and all that, but this is got potential if this expands to other things, that we're going to be cops, that we go out and just check on the public in more and more different ways. I know we do, nicotine sales, all that stuff. It's just a concern that I want to put on the record that I have.
Understood. And it is stretching the health department, that's for sure, this additional responsibility that we have to, enforce that part of the sanitary code.
And due to that, I would actually like to motion that we stop the incremental $50 followed by $1,000 and just go straight to the $1,000 as is the standard in other counties.
I'm not in favor of that.
This is Ralph. What do you think, Eileen? Obviously there's been more fines. Whether there's an understanding now amongst the vendors in our community that this is required. Do you find that to be true, Eileen, or is it mostly a matter of simply being ignorant of the regulation or willfully violating it? How would you put that?
I don't think most people are willfully violating it. Over the number of months here, you've seen a number of consent orders that I've brought, and Most of them have not repeated. It was a one and done type of a thing. We have had some that have repeated, but a small percentage of those. The only thing, my only thought, and this is only from a staffing perspective, I would imagine that most people are not going to sign the consent order for $1,000. So then we'd have to take them to a hearing, which is, a lot. It takes a lot more staff time to summon somebody to a hearing. I mean, just the summoning is a process, because we have to make sure everybody receives proper notice, that everybody has due process. And then quite often, because the stakes are higher, they get an attorney involved, and then the county attorney therefore gets involved. And it is, sometimes the enforcement is slower when the penalty is so much higher. So that's my thought. And, and I think, my first point is that most of the people who violate one time, most of them do not have a second violation. So it seems maybe to be working this way. Not everybody. I do have some that aren't.
Eileen, did you say last month or the month before that you're no longer doing the education call? You're just going right to sending someone after you get a complaint and then moving forward with the consent order?
Correct.
So it used to be there was this call and say, we've got a complaint, please, but you're not doing that one phase any longer.
No, we're not, because we figure at this time people should know about it. And
there is no law enforcement way to enforce this. There's no interest in it, and it's not illegal. This is why it's fallen to the health department?
No, it could be through law enforcement. And I know Kathleen's had conversations, and I've been part of some of those conversations with the law enforcement and with the DA's office, and there really isn't interest in pursuing it that way at the present time.
So basically there's where the enforcement is now falling through the Board of Health and the hearing officer and all of that.
Correct.
Well, if it's actually going to create more work for the health department, then I'll withdraw my motion. My idea was that I just feel like it's a slow drip torture method for you guys to continually keep slapping a $50 fine and then following it up. But if it's going to create more work, never mind.
Okay.
I hear that it seems to be working. At least the folks who would normally comply will, after that first fine. And other folks certainly, may have their own views on it, and they're going to follow their own course of action. But this seems to be working. I'm in favor of continuing with the current course myself.
I think several members here have sort of expressed the understanding that the fines really serve as the way for the Department of Health to sort of enforce its desire for compliance. And I think that it sounds like the stepwise manner is probably the best approach at this time. So unless anybody has anything else, I guess we'll ask Eileen to continue with any updates she has.
Well, just one last thought, and I know, taking everybody's point of view, of course, Brian expressed his concerns, and there's concerns on both sides. I think trying to split the difference, or at least having some sort of policy that ultimately gets us to where we want to be without, really overdoing it and creating other problems or other perception. I think we seem to be doing it right.
Okay.
Do
So
we
moving.
the motion to approve?
I'll motion to approve the claims.
I will second.
Any opposed? Okay, we'll accept the claims. Thank you. Go ahead, Eileen. I'm sorry.
Oh, no, I totally forgot about that part. So I did get a report from the watershed inspector about the farm on Ensenor Road that was discussed about a year ago. And so it was reported that through regular surveillance, either weekly or bi-weekly by the inspection division, they have not witnessed nor received complaints of manure or contaminated water flowing down the hillside and collecting in the road ditch along Ensenor Road. The farm is no longer a dairy operation. It is now a beef cattle operation, and they are rotating the beef cattle through a series of large pastures around the farmstead and maintaining a grass stabilized area where the concentrated flows had been flowing from the barnyard to the road ditch. So it appears that they have eliminated animal access to the area that was causing a lot of the problem. And so it appears that what the farmer has done has corrected that problem. And they will continue to monitor the situation. So I just wanted to bring that to everybody's attention. Any questions on that?
No, thanks for the update. That's good to hear.
Okay.
Okay.
And then the last thing is we did transmit the rules and regs of the watershed to the Department of Health last week. And so now it's in their hands to see what they do with it. So I will keep you posted on any developments we hear.
So that's gone to the state now. They're obviously very busy. Can we expect that it's going to be even slower than it would have been?
Yeah, and I have no expectations, actually. I have no idea. I wouldn't be surprised if this takes months and months and months. I would be really surprised if we heard something within just 1 month. So I have no idea.
Well, good work on that. I want to congratulate everybody that worked on that watershed rules, because that was a huge project.
Yeah, it was.
Yeah, this is Keith. We did pass a resolution in support of that last month, correct? I just wanted to confirm that.
Yeah, and that accompanied the package.
Great, good. Thank you.
Okay, very good. Anything else, Eileen?
No, that's all I have. Thank you.
All right, well, thank you and have a nice holiday.
Yeah, you too.
I guess I don't see Kathleen on the call right now. She's not on the call. Should we move on to Nancy?
Sure.
Nancy, you're muted if you're trying to talk.
Still muted.
Still muted, Nancy.
I see your mute button going on and off.
Well, we are.
There you go. Don't do anything.
Let's see if it stays off. Okay. Good afternoon. The numbers related to COVID change on an hourly basis. But the latest I have right now for this meeting is that we have 198 outstanding positive cases that we need to enroll. We have 431 cases that are under suspect. So we've enrolled them and waiting for results. We have over 3,000 persons that are contacts. They are both persons that have been informed and enrolled and those that are not. The state is assisting in managing the contacts. We have, at this hour, we have 23 approximate clusters within the county. that we're working with. We have 29 positive cases in the local hospital, with 3 of them being in ICU, 1 being an OB, and the others on the COVID floors, whatever how they're doing. So that's kind of where we stand with numbers. We're finding in our
Actually, I'm
conversation-
sorry, this Keith, can I stop a minute? Forgive my
Yeah.
ignorance. You said OV. What is OV?
Oh, obstetrics.
Oh, thank you. Thank you. I thought it was
Yep.
OV as in Old Vienna beer. And I thought that's weird. Thank you.
Yeah.
Sorry.
So what we're generally experiencing when we talk to people is when I compare it to earlier in the year, there is greater understanding, there is greater concern, there is less anger because it's become more personal, I believe. We do hear significant grief all day long. I mean, and some of the stories are, very touching, very sad, and we do try to help them navigate with the challenges they have. We had to put in place, and we're still massaging it, is that we were at one time calling people daily. So if they had questions, concerns, you could address them to try to keep them retained into quarantine and isolation. Well, there's just not enough. We are unable to do that. And I don't know of a county that is doing it. But what we did put in, because we did sense, and we did see a loss in having that ability. We were seeing hospital admissions because we couldn't get to those people. We attribute some of that to the inability to touch base. So we are put in place where we're calling them on the 5th and 10th day. And we have seen I think it's a very beneficial process. Because on that 5th day, if they're having any trouble, we want to get them to care and really encourage and help facilitate that to avoid hospital admission. So that process we're still working on. We have non-nurses making those calls. And then when they identify an issue, it's turned to a nurse. In regard to, and you may have some questions around that,
Yes, Laura, I just want to jump in, even though it's the 5th and 10th day, just so they understand that they are still daily phone calls. Like, we are making volumes of calls on the 5th and 10th day for everybody, but it's still daily.
Right.
So you can
Yes.
see that.
That's correct. That is correct. Then we are, in relation to vaccines, all the counties, and I was on a call yesterday, are really surprised that there isn't been, the counties have not been included in really being a paramount member to orchestrate the rollout of vaccines. And I think it's still in the works, and I think there will be some refinement to that. Yesterday, what was reported is beyond hospital workers and first responders, that rest of that matrix has not been completed, and that will be released to us sometime. So we haven't been able to adequately answer a lot of questions that are posed to us in regard to the vaccine rollout, because we have not really been clearly informed of what the local health department role will be. It's a work in progress, I believe.
Nancy, are you saying that potentially the local health departments will not be charged with setting up mass vaccination clinics? They're going to look to others to do that? Is that what you think, or you're just not in the loop on the original allocation of vaccine that's coming?
Well, from my understanding, and yesterday also being included in that meeting, the health departments haven't been informed that they're going to be participants, but it's hard to believe that we're not going to, because it's the health departments, not the hospitals, that have the plans, that have the pods, have orchestrated and practiced this. So I think the counties expect that they're going to be involved, and they want to be involved in that whole process. So.
Yeah, I mean, I initially thought perhaps there was already the sense that the local health departments are totally overwhelmed and that perhaps they were trying to not continue to burden them. But again, that was my initial thought, because I do understand that those are the things that you guys have practiced.
Well, that's what I thought too, Elaine. I did think that maybe they were doing that, but really, I don't know. I asked that question because I thought, well, could someone explain their rationale so we understand why they did? Well, nobody knows that.
Okay, thanks.
Nancy, do you know if the County Board of Health has the kind of refrigeration units necessary for these 2 vaccines that we've approved?
Not for the Pfizer, no, and no one even in the county here does. Even the hospital. The hospital had a plan. They were going to put it on dry ice and have means to monitor that. But as all of you know, that will be a challenge. Actually waiting for that second vaccine, which would be more applicable. Now, my understanding is that there were doses that Upstate made available to staff at the hospital, and there were staff members that went over to Upstate and were vaccinated yesterday. Possibly today, I don't know. I haven't received an update about that today.
Nancy, I find it pretty terrifying that that we're running 200 cases behind each day. Is there anything from our standpoint that we could do to support the state giving you guys more resources with contact tracing, or asking the county to free up more funds to hire more staff that would be appropriate for investigation?
Well, we've had multiple conversations with the state, and the state, unbeknownst to us, diverted the team that was working on contacts and was training them for doing cases, which we did not know about that. So you can imagine the curveball that threw us, and they understand that. We voiced that to them. Their intent, and we have several other meetings lined up here too, because it takes so long to get through everything, but they're going to assume a role in doing cases.
What do you mean by doing?
Possibly before
doing cases mean?
by enlisting, by doing the intake of the positive case,
Okay.
the positive case. So their goal is, and they really want to help. That will be they hope to do that before the end of the year. Again, they're bringing people on to do this. No, go ahead.
It kind of segues into a question that I wanted to bring up during this meeting. The question is, how close is the health department from complete collapse on being able to trace contacts? And the reason I ask that is, I've heard that some people have gotten tests at some of the clinics and testing opportunities, and they haven't heard their results promptly. And I would think that the priority would be much more important to notify people of their test results very promptly so that they can alter their lives, rather than to put a lot of resources into contact tracing at this point. Now, in the past, when there weren't that many cases, contact tracing was valuable. But when it gets to the point where it's so ubiquitous now that it's very pervasive, prevalent, and you can catch COVID anywhere. You can touch a pomegranate at Wegmans and catch COVID. So I think, in my opinion, I'm wondering, is the value of contact tracing now taking a backseat to the value of maybe kind of priority tracing, that you could tell someone, look, you got a positive test. everybody kind of knows what they got to do. And I think everybody's very cooperative with it. And you could just say, look, you're positive, you've got to stay isolated. And then do you have contact with people in nursing homes or whatever? And just kind of do like an abridged version and try and keep the what do you call them? Not pods, but the clusters, keep a vision of the clusters, but not do as much contact tracing. I know you've knocked it down to the 5th and 10th days out of necessity. And I'm just wondering what your take is on that, Nancy.
Well, yeah, I can't speak for the process collapsing, but I can speak for myself. I'm collapsing.
Yeah, that's a real concern. This has been going on for 10 months.
It's interesting. I only give my personal opinion here. Yeah, I do feel, and I think certainly team members feel that, and we've put in some good processes and we've augmented the team. We have like 16, 18 people working today, remote, and I just got off a huddle with them. And so we've beefed up that. We've beefed up the organization of it. I think it's remarkable what is being done now, but you have to question the value of it. And I've asked and been on calls with the state, who's evaluating the effectiveness of this? I have to question the same. I think we need to put a lot of energy in, and actually Kevin and I are leading the charge, hopefully, in regard to the vaccination. That is where we can we need to really put some emphasis once we get some more information and when we can start rolling. I don't have an answer, but I certainly appreciate the question and the concern.
Is there a delay
Yes.
typically in informing people? Is there a delay typically in informing people of their test results because you're overwhelmed? Does it take a little while sometimes?
With the results, well,
So
you know what? Oh, it is such a challenge because what we've done is, and we're working in coordination with the hospital with this, which is great, and patients can access that result through the portal. We've had to refine that process so that would work. So it hasn't been perfect all the way. And then there's people not capable of doing that, and they call here and they're looking for the result. And there are so many calls coming into the health department.
I just think
can't
that
even
should
keep up.
be a priority to get prompt notification of the positives.
Yes.
With no delay. No delay.
Now-
Like no delay. You know, you might catch them before they go to a meeting or something if you get them in time.
That's right.
Well, tomorrow,
And so you're
that's just like you let a horse out of a barn.
Yeah. And I don't know whether what they are getting reported if they're positive. I need to spend a few moments on that and look at that again. That has been a work in progress, but everything takes so long. It's again, similar, going back to the state helping us. That sounds good. That sounds good, and we really could use that. But then, that creates a whole different issues. Like, we went back and forth with them, and they did buy into it. And I think it will work for not only this county, but they might adapt it in other counties. They need to look at clusters. They need to evaluate whether the person that they're doing the intake belonged to a cluster. Well, that's not their job. That's not what they do. Well, then it's little help to us. We need that information. Well, they did support that, Nan. That was great. But it's all those kind of issues about each and every problem. But we do have, with the people that are the ComCare system, I think we have mutual regard, really do. And I think we've had some very good conversation.
Nancy, this is Ralph. The ComCare is relating to the actual posting the numbers, correct? So that part of your responsibility of the Cuyahoga County Department of Health responsibility is being managed by the New York State Department of Health. The numbers part of it. Is that what I'm understanding?
Well, they don't, maybe I'm not clear on the question. They provide the system by which we're tracing and tracking all these cases. So you would think that's where the reports would come out of. The state has not found that to be a reliable source of numbers. Again, it's relatively a new system. Reporting is, so I don't.
No, actually, Nancy, is the question, the positive result goes into the Eclair system or negative?
Oh,
it starts there?
Oh, yes, okay. Now, thank you for that. Yes. What happens is it goes through the state system as all the reportable diseases do, and some of you are very familiar with that. And then it has to leap into the system by which COVID is monitored. So people will know the result before we know. We used to get, it used to be, and it wasn't our system before, was not perfect, and I don't think our system before would ever be able to handle the volume we have now. But what we used to be able to do is we'd get those calls, we'd get those reports, doctors would send us reports, and we'd act on it. Well, now we have to wait. We really got to see it come through the system, and that can take up to 2 days from the time the report is known. Now, what we can do, and what we do when we, in circumstances, and I've done this, yes, I did this last night, is we can put that in as a PUI, that we've got somebody under investigation. They may have symptoms. They know they've been reported a positive. So that's why we have 431 PUIs. One of the reasons why we have, a big reason why we have that many PUIs. Yes.
So is ComCare nothing more but a more centralized statewide system? So essentially, instead of putting it into the local system or inputting into the local system, we're inputting it as a statewide system. Is that what is happening now?
Yes, and it certainly is easier to transfer cases. So if you have a case here, you have a correctional officer that lives in Onondaga County, but his contacts all live in this county, then they can easily transfer those contacts to us and vice versa. So from that perspective, that is very helpful.
But the input part of this is, excuse me, Nancy, but I just want to make sure I understand this clearly. The system is also causing a delay in people being able to access their results because of slow input, or is there something that I'm missing here?
Well, yes, it's one of the reasons, but not necessarily the biggest reason. The biggest reason is we have more volume than we can deal with on a local and state level. And for the question that Dr. Brundage brought up, do you need to re-examine, maybe this isn't where we should put our effort. But see, we're taking orders from the state, and they haven't called for my opinion yet. But I'll be willing to give it to them when they call me.
Well, one last question, Nancy, and I want to make sure I'm clear on this. This is important. Is there delays in people receiving their test results because of some administrative issue?
Could I?
Any issues causing delays?
So for example, if a patient. Oh, sorry. So Ralph, if a patient is in my office, can you hear me okay?
Yes.
Okay. So if a patient is seen in my office and we test them, we will call them with the results. If they are seen with a positive result, if they're seen in urgent cares, some of the urgent cares have an electronic record that they can go to access their results. The same with people who are getting tested through the hospital symptomatic screening. There's a electronic portal that they can go and access the results. The patients who are getting screened through the health department at the Emerson Park walk-up, they get their results at point of care because those are rapid results.
Yes. Where the delay is,
Go.
the delay is either people that can't access electronic systems and get their results, where they don't know how to do that, is one way. Secondly, what they're waiting for the most part for is they learn of their results, but they haven't heard from the health department to put them in isolation or, isolation. They are instructed, and we give copies and we have everybody educated that when we're testing, you have to tell the patient that if they are positive, they are to stay home and wait for a call from us, because there is that delay in us getting to them. So even if the system was timely and we got everything organized and it flowed through the systems and we got it within 24 hours, we still don't have enough manpower. You'd have to run 24/7 to be able.
That was kind of my original point, is that I think in a disease control, if the disease control is the priority and people are very symptomatic, very infectious before they become symptomatic or around the time when they just become symptomatic, it's absolutely crucial that they get notified immediately. And the resources should be skewed towards that as much as necessary. So they're immediately placed in isolation and educated on what to do. And the follow-up isn't as important, because I think people get it by now. They just need to know, because I've heard through the grapevine in the community that people have gotten their results a day or two later, and they didn't know whether they should go out that night and go bowling or whatever they do. And I think that's a problem.
So the issue isn't really getting the results. The issue is being contacted by the Department of Health and being instructed to isolate. Am I understanding that correctly?
Well, yes, and then
So people do know what the results are.
Anyone who's symptomatic should be told to stay home until they are contacted with their results, whether they are positive or negative. And then even if their results are negative, if they're still symptomatic, it might need a reevaluation in case there is a false negative.
We're also seeing a high transition from being quarantined, a contact, and turning positive. So that is another area of, and that brings me to another thing. We're grateful for all the testing that we're able to do now. We know we needed testing. That we absolutely needed that. Unfortunately, people are relying too much on the testing, so that, Brian, that was a good example about, if I test negative, I can go bowling. Well, not necessarily.
Or if you haven't heard your results, you can go bowling. That's what I think. And what I'm getting at here, my whole focus here is there a point of failure that we can identify and possibly do something as a board to maybe put pressure on whoever it is that makes the software or whoever it is at the state? If there's a choke point that is somehow related to state administrative issues, we could maybe address that as a board, write them a letter saying, look, you guys got to get a little bit quicker with your notifications, because all the quarantining and contact tracing is futile if people who are infectious, and the worst ones, of course, to Cassie's point, are the ones that don't feel sick yet. The ones that feel sick, that we tell them to stay home, and I think people kind of get that. But if somebody has a positive test and they don't really feel sick, like they've gone from quarantine to a positive, they need to know about it really fast before they go out bowling. And is there a choke point we can identify that maybe we can address?
Well, who in this country who has a positive test doesn't understand that they need to stay home? I don't understand.
Right. That's why
anybody.
promptly.
I mean, if I've got a cold or flu, I should stay home.
Right. That's why they need the prompt notification. And if there's a delay point, that maybe is there something positive that we as a board can do to address that by putting pressure on it?
Yeah, and I appreciate what everybody's saying here, and I think the state would answer that they have already recognized this, and that's why they took their team that have been doing contacts and train them to do cases. So they intend to help get more cases done because they see the value of that as well. But that threw us a curve because that's how the numbers of contacts grew. And plus, people have more contacts now. So where we were averaging 2 to 4 contacts per case earlier in the year, we are now on the average 8 to 10 contacts per person. It's a lot of calls.
Well, you guys are definitely overwhelmed, and I think everybody's called that this day would come. I think most people who saw what was happening understood that this day would come. And ultimately, we all have certain responsibilities. The health department is overwhelmed. The local governments are overwhelmed. State governments are overwhelmed. This is a big issue. And I think there comes a time when all of us, where there has to be very good communications. From the point of contact, from the point people receive tests, get that information, positive, stay home, do as much as possible with as little as we have. But there comes a point where someone who tests positive, who willfully goes out, that's on them.
I don't think we're talking about that. I'm not talking about that. I'm just talking about people need to be told their test results when they're positive. They need them to be told promptly. And if there's a problem with that, then maybe that should be addressed.
That's where I'm hung up, Brian. I don't understand. It seems like that's not happening. Or is it happening? Or am I misunderstanding this?
I
There's
think
a
that some,
30-day turnaround for test results, and during that time frame, if they're not having the rapid results, and during that time frame, again, typically, at least it's my practice to tell people while they are awaiting the results, they go home and they stay home until they hear from the results. So, and I don't know if people are not here or being told at other.
Well, yeah, and like I said, we've used the electronic system with the hospital, and that's how we've attempted to remedy this. But obviously, there's still a problem. And it's under Dr. Joya's order. Dr. Joya, do you have any thoughts as to how this could be done?
I have been getting the reports, and I get them. I contact the people if they don't have primary care docs. I'll forward the results to the primary care doctors. So I try and give them a heads up before the contact tracers get to them, but kind of hit and miss there. Sometimes I get them, sometimes I don't. I did get a bunch on Saturday, and I had some spare time. I took care of those, but just I'll try and get the information out. I try to ask the hospital to try and do send the information to the primary care docs, and once the stuff gets from the hospital computer, lab computer to the Medent, Medent has a primary care doctor listed. Some aren't always up to date, especially like middle-aged guys who don't usually see doctors for 10 years or so. But if they we don't get if the primary care doctor doesn't see them, if we get the messages back, we'll call them directly. But we just give them the basic information to isolate and quarantine if there's positive, and if they're negative, just that result. And
I have a call with the hospital tomorrow, and I'll bring this topic up, and maybe we can brainstorm and think of something that we can do that might be more.
Yeah, the hospital also interfaces with the eClair system, the lab reports. Any lab has to report to the state hospital infectious disease or reporting system, but it's that's like a 1 or 2 day delay often, and there's no interface to the doctors or primary care docs. except once the health department gets that information. When there wasn't much infectious disease around, that was pretty useful because the health departments weren't overloaded with significant cases. But now it's not too practical. But keep working on it for sure. And when you get so much COVID around, I think like the governor and Dr. Fauci say, just kind of quarantine and isolate as much as you can if you're not working. And when you're off work, try and be as careful as you can, for sure.
Mhm.
Okay, well, my point, I think, remains that there is room for improvement on information of positives, of informing positives. And that's something that maybe we ought to keep in mind.
Oh, I hear you. Yes. Uh-huh.
I think it's crucial to make the disease if you're positive. What's the sense of all this testing if you got to wait 2 days? And I'm not saying everybody's going out and being intentionally evil, but if you're, any job, anybody who has a job and they say, well, goodness, we got Christmas coming up. Why don't we get a test? And they get a test and it's positive. They don't hear about it for 2 days. Meanwhile, they've been doing their job because they still don't feel sick. They should have been told immediately that they were positive. So I don't know if this is a problem. I'm just sensing.
No, there is, and there is that problem, but the larger problem is they know the result, but they haven't heard from us. Okay, that's probably the bigger problem, but both of them are issues.
Yeah. One last question relating to that. So, in my understanding, that the delay problem is really a question of the labs, getting the results back from the labs, and that the issue with, if there's any issue with the health department, is communicating with people who receive a positive test to ensure that they quarantine and so forth. Is that what's going on right now, or is there something I'm misunderstanding still?
Well, it's not all the timing and getting the results back, because that has improved. It can happen. It can, in fact, people are getting accustomed to getting 2-day results back. And when it goes to 4 days, that is alarming to them, but that can happen. It's about the volume. I think it's the volume. That's more the issue. And the number, huge.
I was just a little confused because it seemed like we're talking about the administrative part of it and also the clinical, testing part of it. I was just wondering if these things, one was impacting the other, or are we dealing with two separate issues here? And thanks.
Well, they're both problems for sure. If you're positive and you know it, it's I think people will take it a lot more seriously, and most people for sure. Back in the days with AIDS, there were some people who were just antisocial, and if they were positive, they didn't change their behavior at all, which was a fatal disease, a lot worse for a high percentage of people back in the early 80s. But those people are pretty rare, and they were, that's when you start getting police involved if you get something like that. People are flagrantly very dangerous behavior. But for this, it's doing the communications, and they certainly public health, law enforcement. That's second resort, and then third resort is it's dangerous to a number of people. Then you start thinking about getting police involved. If there's people who have malignant problems, and a lot more problems than just the disease, but social problems too. You can get back in the bad old days, there'd be things like legally enforced quarantine when you had things like typhoid and smallpox and stuff. Those were were serious, highly fatal problems, and it was sometimes it was legally enforced quarantines, and isolations. But hopefully, we're not going to get to that. But there's precedent in the past.
We're
These are
doing,
really scary times. I just want to make sure, and that's the reason why I kept asking those questions. I just want to make sure that the
Result, if there's anything that the board can do, let me know.
right, and just so you hours, so we're doing between the hours of 8 and 8 p.m. So we've extended the time. We're doing 7 days a week. We've enlarged the team, always looking for opportunities for improving efficiency and effectiveness equally. We've been in conversation with state, so they're going to come on board. And we didn't jump on that. They've done Onondaga and Ontario. Those are the two counties that they've been, and it's only been 3 weeks that they started doing cases. And they extend, they plan to do this for Cayuga. But we didn't jump on immediately because we wanted to talk to them to see how they were going to handle it. We need to know clusters. We need to have an understanding of schools. How are schools going to be handled? And we want to make sure they're handled well and that we're knowledgeable about what's going to happen. So we've had those conversations and I think they've been fruitful. So there'll be more to come. And please call myself or Kathleen with any question or concern, but I am taking this conversation and I will be talking about this further. And I will have a conversation with the hospital tomorrow. We'll talk about the results. And I'll tap in to Dr. Joya.
Please accept all of the board's thanks for all the hard work, and do not take any of this as a criticism, because it's not. It's more meant as an offer that if the board has anything to help you with, if you have an identifiable issue that the board can do something about it, let us know.
Oh, and I take it just that way, and I appreciate the conversations. And there has been a concern, I can tell you, that you really wonder whether all the effort is, are we getting the bang for the buck? Yes. Yes.
All right, thanks so much, Nancy. Is there anything else?
Not for me.
Okay, we'll move on to Dr. Joya then.
Before we move to Dr. Joya, I think we need to, Kathleen talked about Keith, his appointment expiring at the end of this month. And so he has expressed interest in wanting to stay on. So we'd need a motion and a nomination and a vote and all that good.
I'll nominate him.
I'll second. So we make a motion then to accept Keith as a ongoing board member.
I'll motion.
Yes.
Okay. For an indefinite amount of time. A life sentence, perhaps.
Does it go by terms? Is it life sentence or does it go by terms?
Okay, great. I'm assuming nobody's opposed. Okay. Anything else, Megan?
Nope, that was just the last thing.
Yeah, and this is Keith. I just want to say thank you for the vote of confidence, although I recognize since I'm listening in, it would be difficult.
Well, think of all the money you saved on campaign expenses. You
Exactly.
got reelected.
All righty, we'll move back on to Dr. Joya. Thank you.
Yes, the main things in public health certainly is ongoing, is improving. I think the community information, the probably primary care interfaces with the health department. Certainly, when you get to infectious diseases, it's especially important. But just the extent of healthcare in the community and interfacing with the health department. That's kind of getting filled in sort of with information systems and interfacing electronic records with regional databases, but it's pretty awkward and pretty slow. The big thing in New York State is which is important all over, is certainly keeping security, privacy, and information systems. So you got that against speed of access and wider access. We always have to balance that, but I think you certainly can do better. There's in terms of interfacing with the information systems. Eventually, the kids who are going up with the information systems are probably gonna adapt very well in the future as they get health problems and seek the information. But I think in a lot of the population, it's tough for them using stuff like patient portals. Supposedly, the hospitals says you can access your information on patient portals. Usually, the portals are set up that the physician has to allow the access to lab results and documents. So even if you get the patients getting the access, which only I think about 25% of my patients can use the portal, some and only like 5 or 10% are really good for it, and 1% are really good because they work for MedEd and they said that they invented it. But it's kind of hit and miss, and that's going to take like whole community infrastructure and public health interfacing. And there's a lot of certainly underinvestment, and certainly in the information systems. Certainly, it's now certainly when you get things like COVID, even just getting people with hypertension, diabetes, obesity to primary care, and you got things like obesity not even getting covered by a lot of insurances, and nutrition and diabetes prevention is kind of hit and miss. So we have the community health networks been working with diabetes prevention, which helps out, but it's work to get the preventive efforts done, and there's certainly a lot of work to do in the future once COVID's gone, and hopefully we won't have anything this bad as infectious disease aggravating problems, but we've got certainly ongoing community problems for sure.
Okay, well, thank you. Thanks, Dr. Joya. Does anybody else have anything else for this meeting? I'll accept a motion to adjourn.
Ms. Batman, I so move.
Okay, do we have a second?
I'll second.
Great. All right. Everybody have a nice holiday. Thanks for joining us for this meeting. I think it was productive. And we'll see you next year.
Yeah, hopefully 2021 is better.
Happy New Year.
Yeah.
Happy New Year.
See y'all.